Yeah, again, thank you. Great, got it. Thank
Please
you.
go ahead.
Sure. Great, yeah. And I just wanted to sort of thank everyone again for this opportunity. Yes, and I did get to meet some of our colleagues now during the last Pathcare event. Unfortunately, I didn't meet everyone, but I hope to in the near future. So getting straight into the talk, let's not get conned. So I think that's one of the big things that we'll see during the course of the presentation. As a cause of hypertension, specifically secondary hypertension, Conn syndrome is something that we need to consider. But I do want to acknowledge before I start Dr. Firdaus Omar. She's allowed me the opportunity to use this talk of hers. So this is what talk that she did earlier this year in Cape Town. She's also a chemical pathologist at Pathcare. So briefly through the outline, just the outline of the actual talk. I'm going to touch on hypertension, things that I think we all know quite a lot about, the various causes of hypertension, just broadly breaking them up, and then secondary hypertension. So looking at the causes, the diagnostic workup in terms of what we have available to us, and then touching on treatment strategies. Okay, so in terms of hypertension, we all know ideally it's between 120 to 80, and that's what we've all been taught through medical school, through our medical career. And we do see some variance outside of a systolic of 120 and a diastolic of 80. But when we start going into the hypertensive patients, there's different grades as they go up in increments of 20 for the systolic and increments of 10 in the diastolic. Oftentimes, I remember working in clinical practice, one does see these patients who just grumble along with a high blood pressure above 140, never quite getting better. And so, rightfully known as a silent killer, we all know that hypertension can be the cause for a lot of significant cardiovascular complications, and those include sort of stroke, myocardial infarct, heart failure, renal failure. The two graphs side by side here below just give us a representation of time and the incidence of cardiovascular disease presenting in both women and men. And what's sort of important to note is that in high normal blood pressures, so even in patients that have a normal blood pressure, they have an incrementally higher incidence of developing cardiovascular disease, and particularly in men. So the percentage of incidence is much higher. And so these are patients that we really need to look at. So despite falling within a normal, a high normal, they do fall under the risk of developing cardiovascular disease in the long run. So just in terms of just broadly dividing hypertension into their different groups, we largely talk about the primary or idiopathic or essential hypertension. So this type of hypertension, sorry, I just want to change my pointer. So we largely talk about the idiopathic essential primary hypertension. So those kind of hypertensive disorders that we can't identify a known cause. But what we'll focus on today is the secondary hypertension. And a lot of the time we talk about these numbers of like 1 in 20 or 5% of the population of patients that have hypertension they present with a secondary hypertension. But literature also does show that if we actually investigate our hypertensive patients, the incidence is actually much higher than just 5% of that population, and particularly in the population where they're drug resistant. So in patients that we've put them on 3 or 4 different types of drugs, including diuretics, just not getting any better, and we're just not able to control their blood pressure. So they tend to have an underlying secondary cause. And they've also divided up the causes of secondary hypertension into a few different categories. So when you look at some of the causes of the secondary hypertension, there are quite a few different endocrine causes. And we're not going to look at every single one of them, Some of them we'll just touch on right at the end. I want to look at the ones that we can particularly do significant diagnostics for, and we can work them up, and they present quite commonly. Other causes under the banner of a secondary hypertension include obstructive apnea, renal vascular hypertension, but it's also useful to note that these have a relationship to endocrine effects, and we'll look at those when we look at the next slides coming up. One thing I did want to point out is iatrogenic causes, so different kinds of drugs that we might give, especially because there's so many different drugs coming onto the market and they're constantly changing. It's very likely that new drugs that we see will potentially predispose or cause hypertension. An interesting note is just licorice as well. That can also cause hypertension in some patients. And we'll look at a mechanism, just touch on that briefly. So the main causes of hypertension that we're going to cover tonight, we're going to look at primary aldosteronism, and that's the most common one. Obstructive sleep apnea, renovascular hypertension, Cushing's syndrome, so high cortisol levels, and then pheochromocytomas, where we're looking at metanephrines. Okay, and so what's the whole point of being able to identify these patients? I think the main cause is that we don't want to miss the opportunity to be able to treat them, because giving them treatment appropriately at an early stage gives them long-term better lifestyle, better outcomes. We can actually appropriately target the management to the disease profile, better control of their blood pressure, and inevitably prevent end organ damage. So those target organ damage issues that end up being complications that we then have to aggressively treat quite extensively. Okay, so who to screen? The big thing about the secondary hypertensions is that it's really about patients that are very difficult to manage, the ones that we're putting them on every single type of drug, but we're not able to get them controlled or get them managed properly. And that includes sort of the drug-resistant induced hypertension, so those that are on multiple different drugs. Some literature says 5 different drugs, including a diuretic. Others says 5 different drugs. So between 3 and 5, the main point is that you are treating these patients appropriately and you know that they're compliant, but they're not getting better. Abrupt onset of hypertension, you can kind of tie this cause with abrupt hypertension with exacerbation of previously controlled hypertension and this accelerated malignant hypertension. So these hypertensive patients where you suddenly diagnose them and their blood pressure gets much higher at a quick rate. It's also important to consider young patients, so these young healthy patients who suddenly have this underlying high blood pressure incidentally found when examining them or investigating them. Some literature says less than 30, but even some literature says less than 40, but even ones under the age of 30, it's important to consider those hypertensive patients. I think iatrogenic or drug use is an important consideration in this category as well. In this category, the disproportionate target organ damage for the degree of hypertension. So you might have a grade 1, so a lower type of hypertension, but significant amounts of target organ damage. Important to consider working up for secondary hypertension. Onset of diastolic hypertension in older patients, so older patients that then have a very high diastolic. And then unprovoked or excessive hypokalemia. And when we look at the mechanisms of how a lot of the endocrine disorders impact the body, we'll look at how hypokalemia can be almost like a marker or a screening test to identify potential endocrine dysfunction. And the idea that we're trying to put across from these points is that we really need to consider screening them quite broadly and be quite deliberate and just to screen a much wider group So I'm going to look at a couple of cases just to highlight the point of these endocrine disorders. So this was from a local case in Pretoria, con syndrome. And so the case revolves around a 40-year-old woman. She had a 7-year history, uncontrolled hypertension and weakness. Blood pressures not significantly high, 144, 107. On ECG, looked like there was some target organ damage, left ventricular hypertrophy. When we look at that biochemistry, we can see that there's this hypokalemia. So that's kind of what we touched on the previous slide. Slightly elevated sodium, bicarb, a little bit elevated, so suggesting that there might be a degree of alkalosis. And we'll look at that mechanism. And then this transtubular potassium gradient. And so what this transtubular potassium gradient is, it just tells you if there's potassium being lost in the urine. So it's not a frequently used marker, but it's a good idea just to be able to see how is the potassium being lost in the urine, or are they just not consuming a large amount of potassium in their diet. And then the renin and aldosterone. We can see from the renin and aldosterone level, it's a very low renin, so less than 4.5. So in the lab side, we would say this is an undetectable renin. And so we'll usually have a less than result. So it's below the level that we can actually test. And when we look at the aldosterone, it's significantly high. It's much higher than the actual renin level. And when you do the ratio, you can see it's probably greater than 95. So we use a 95 cutoff for the aldosterone-renin ratio. And so the diagnosis in this patient was primary hyperaldosteronism, known as con syndrome. And so primary being the cause of the raised aldosterone is within the adrenals itself. So rather than a secondary hyperaldosteronism, where it might be something outside, like something outside pushing up the renin, then therefore pushing up the aldosterone similarly. Okay. So just looking at primary aldosteronism, it's important to be able to consider these causes because it's a very common presentation. And it's probably the commonest cause for secondary hypertension. When looking at the incidences of secondary hypertension, it's about 20% of the secondary hypertension cases. You get this increased unregulated aldosterone production. So you get this aldosterone level, which is exceedingly high, despite trying to control the sodium, the fluid levels of the patient. This aldosterone is significantly raised. Now, in terms of the causes for primary aldosteronism, or primary hyperaldosteronism, the main cause is the benign adrenal adenoma. So in the picture on the right over here, this is an adrenal that's been taken out, and there's an adenoma located within the tissue. But other causes include bilateral adrenal hyperplasia. So this is an increase in the size of the tissue. Normally, you would see it on both adrenals, so left and right, but you can also present with a unilateral hyperplasia. Other causes might include malignancies in the adrenals, so adrenocortical CAs, multiple small clusters of these aldosterone-secreting benign tumors, and also familial hyperaldosteronism, which is autosomal dominant. So you might see other members in the immediate family who have increases in aldosterone. The main textbook presentation of these patients are they're hypertensive. So that's the talk itself. So hypertensive patients, potassium goes down, you have a mild increase in their sodium, and they also have this metabolic alkalosis. The main treatment, especially for adenomas, is to treat it surgically, especially if it's on the one side. And if there's hyperplasia, because there's nothing that you can really take out, you would treat them medically. So antihypertensive to try and control the amount of aldosterone being produced. So when we look at the mechanism for the raised blood pressure in Conn syndrome, we're really looking at how the renin-angiotensin-aldosterone system is affected. So just as a recap, physiologically, the renin-angiotensin-aldosterone system is activated by either low blood volumes reaching the macula densa of the juxtaglomerular apparatus. So decreases in blood volume, decrease in blood pressure, and also low sodium reaching that area. And that's low sodium within the tubules itself. One other cause is beta-1 stimulation, so sympathetic stimulation of the adrenals. Further on from that, we can see that when we get the stimulus of either low blood volume, low sodium, or beta-1 stimulation, we have renin release. Renin converts the angiotensinogen, which comes from the liver, into angiotensin 1, which then gets converted to angiotensin 2. And so you get this increasing angiotensin 2, which can cause an increase in the sympathetic activity, increase in antidiuretic hormone and thirst. So it causes you to retain water, to drink more fluids, narrows up blood vessels, to increase pressure, to try and improve flow, to improve circulation to the distal tubules. And then you get an increase in that blood pressure. Additionally to that increase in angiotensin 2, you have an increase in aldosterone. And that increase in aldosterone causes sodium and water reabsorption in the distal renal tubules. Okay. Further on from that, the idea with the renin-angiotensin system is that increasing blood pressure should cause a negative feedback response on that renin and then decrease that renin, because you have an improved blood volume, blood circulation to the distal tubule, and increasing sodium. So this is an important slide just to think about and to consider, looking at the renin-angiotensin-aldosterone system, because it also points out targets for treatment. Okay, so when we're thinking about aldosterone, specifically on the cellular and the molecular level, we're looking how it can increase the blood pressure, specifically as it relates to this part of the slide. So increasing in aldosterone, increased sodium and water reabsorption. Okay. So there's an increase in aldosterone. That triggers the mineralocorticoid receptor in the distal convoluted tubule. And so that's a distal renal tubular cell. Once you have stimulation of the receptor, it triggers off a response to increase the amount of sodium that's reabsorbed. And with that reabsorption of sodium, you're pushing out potassium or hydrogen, depending on what you have available. Okay, and this is really the marker of why you have the clinical presentation or the biochemical presentation of patients that have an increased aldosterone. So just to recap, you have an increased aldosterone triggering the mineralocorticoid receptor. You're going to reabsorb sodium, and so that increases your sodium, causing a hypernatremia. You're going to push out potassium and hydrogen into the urine. So this is where the urine would be located. And that would cause the evident hypokalemia and the subsequent alkalosis that occurs in these patients. We just have the sodium potassium ATPase because this controls the gradient and allows this transfer to come through of sodium. But the main thing is to focus on the transfer of what's happening at this point. Okay, so additionally, it's important just to think about the drugs that we're using at these different sites. Spironolactone. So we all know spironolactone is a potassium-sparing diuretic rather than Lasix or hydrochlorothiazide. And that's really because it blocks the aldosterone receptor, prevents the sodium from getting reabsorbed and the potassium from getting kicked out. So we're holding in that potassium. And so that actually affects the ability of aldosterone to cause this hypertension locally at that site. One other target that you can use to treat for hyperaldosteronism is amiloride, and this blocks this ENaC channel. So the ENaC channel is the channel where the sodium travels through. So if you're preventing sodium from being reabsorbed, you're preventing the ability of sodium and water to get pulled back into circulation, and you're preventing potassium and hydrogen from getting lost. So these are two particularly important spots to consider when treating patients with hyperaldosteronism. And so who do we investigate for Conn syndrome? It's really those with high blood pressures, but again, it's these difficult to treat patients. So blood pressures persistently elevated on 3 different medications, including diuretics. We talked about that hypokalemia in patients that might present with this persistent ongoing hypokalemia and they're not getting better, even though it might be due to medication that you're giving, so diuretics like thiazide diuretics, like Lasix. It's important to still consider that perhaps they're losing it for some other reason. If they do imaging studies of the adrenals and you find an adrenal incidentalloma, especially when it's coupled to the high blood pressure, important to consider Conn syndrome. Obstructive sleep apnea, I'm not going to talk about this too much because we'll touch on it when I talk about obstructive sleep apnea. And then also patients who have a family history of Conn syndrome, so the familial hyperaldosteronisms. Patients that have an atrial fibrillation. Because of the electrolyte disturbances, atrial fibrillation can be a consideration. And also that end organ damage greater than the expected damage for the type of blood pressure the patient presents with. And so these are considerations of in-organ damage findings. The increase in ventricular hypertrophy, diastolic dysfunction, so if they're losing albumin through their urine, and chronic kidney disease. Okay, and the main thing to think about is that when you're thinking about Conn syndrome, you're really thinking about the previous slide that we looked at, where we're looking at the effect of the renin and the aldosterone together. And so that's why when considering hyperaldosteronism, look at the aldosterone, look at the renin, and the ratio and the relationship between these two analytes. So when we think about the aldosterone, I'll just touch on that result. Let me just go back a little bit over here. Sorry, this is going back a little bit further. When we're looking back at this patient, you can see that this renin, it's basically in the ground and there's not much renin available. And then there's extremely high aldosterone. So when you do that calculation, you can see there's a significant discrepancy. Okay. So I want you just to keep in mind those results that we looked at. So we have this high aldosterone, significantly elevated. We have a renin that's suppressed, and that's appropriately suppressed, because if there's a high aldosterone, you expect a renin to be suppressed. And with the aldosterone-renin ratio, we look at this cutoff of greater than 95. So if it's less than, some literature says less than 91, less than 90, but if you have an aldosterone-renin ratio of greater than 95, then it's very likely that you're dealing with a hyperaldosteronism. Coupled to that, we also look at an aldosterone greater than 350. And when we talked about this patient, I think it was about 2,000. So there's definite markers for a diagnosis of primary hyperaldosteronism. So other confirmatory tests that one can do, there are things like saline infusions, captopril suppression tests. The principle that you're trying to think about in this case is that because there's a high aldosterone, you're trying to suppress aldosterone. So if you're giving salt and saline, you're increasing the amount of fluid and salt getting to the macula densa at the juxtaglomerular apparatus, and you should essentially suppress the aldosterone. And so that's what you're looking for. You're looking for a decrease in the aldosterone. Perhaps maybe now, as a rule of thumb, it's always nice to think, it's always useful to think about whenever you're thinking about any endocrine disorder. If you're looking at a dynamic function test, you're looking to do the opposite of the pathology that you see. So if you have a pathology that has a high level, you want to try and suppress it. If you have a pathology that has a low level, you want to stimulate it. So just to reiterate that, we have a high aldosterone, and so you're trying to suppress it by increasing the amount of saline and fluid, and even captopril, because you're suppressing that angiotensin aldosterone system, the ACE inhibitors. And then finally, to localize the lesion. Either you're doing a CT scan, or else you're doing an adrenal vein sampling. What adrenal vein sampling is, it's quite a difficult surgical intervention that they can do, but it basically looks at putting a catheter through the femoral arteries, feeding it into the adrenal vein sites, and then collecting blood from those sites to localize where the aldosterone is coming from. And so that gives you a good idea of the location of the lesion, if it's either hyperplastic or if there's an adenoma locally in one of the adrenals. But I think in terms of what we want to do initially, aldosterone, renin, angiotensin aldosterone, the aldosterone-renin ratio. So that's our first line of investigation, the mainstay, and we're really just looking for these changes. So an important consideration is that there are drugs that can affect the aldosterone-renin ratio. So patients we need to stop these medications before we actually do the renin and aldosterone levels for the patient. This box actually just tells you the direction of the impact that medications can have. And here we're looking at how long before the actual test we need to consider stopping these medications. And granted, it is difficult, especially because these patients are difficult to manage in terms of their hypertension. But it's important to consider that these might impact the patient's results. So if they are on some of these drugs, when the aldosterone and renin is collected, if the result is negative or it's equivocal and you're not entirely sure, it's important to consider maybe repeating the test, but then stopping these medications outright. Okay. So just to recap on the patient, we talked about all the different results. Again, that hypokalemia, that increase in sodium, this alkalosis, the patient's losing a lot of potassium. So a level of greater than, I think, about 2 or 3 suggests a loss of potassium in the urine, and the significantly low renin and high aldosterone with a very high aldosterone-renin ratio. And so this is a typical picture of what you would see in a primary hyperaldosteronism. Just out of interest, and this is really not sort of a focus of mine, but on the CT or in this imaging study, you can see on that right side, there's a point that's lit up, and that shows the lesion that they found in this particular patient. So patient had adrenal adenoma, which I think was removed subsequently. Okay, so the treatment for this particular patient, because it was localized on the one side, they had a laparoscopic adrenalectomy, and that improved her hypertension and her metabolic disturbances. Okay. This slide is really just to sort of point out the clinical cases that have been documented, or at least written up, and that is available. It just shows you the clinical presentation they had. They all had hypertension, but a few other vague symptoms. So muscle weakness, paresthesias, patient had seizures or headaches. So it is difficult sometimes to really identify the cause, or at least know which of these patients has a hyperaldosteronism. But the hypokalemia is a very good identifier for potentially high aldosteronism. Okay, and so I just wanted to point out with this slide, in terms of the drug therapies that you have available, mineralocorticoid receptor blockers, and so that was that spironolactone we talked about, ENaC blockers, so amiloride to block the ENaC channels, ACE inhibitors, angiotensin 2 inhibitors don't really have an effect because it doesn't actually suppress the tumor itself. It's too far down, it's before the actual effect of the aldosterone, so they don't really have an effect. Some literature seems to think that there is some impact, but biochemically, you really want to be looking at your spironolactone and your amiloride to try and treat these patients. Okay, so then with obstructive sleep apnea, and it somewhat rolls on from the primary hyperaldosteronism, but it's also a very common presentation. Patients that come with increased body habitus, raised BMIs, also present with a multitude of different kind of symptoms, which are very difficult to manage. So memory loss, attention deficit, depression, fatigue, even impotence, sexual dysfunction, insomnia. So these are very difficult patients to treat. But why it's also it's relevant in terms of the endocrine causes is because there can be a relationship between primary hyperaldosteronism and obstructive sleep apnea. Some literature suggests which one of the two comes first. So if there's an increase in aldosterone, that can increase the amount of fluid retention, increase the amount of fluid that gets retained around the neck, and also lead to obstructive sleep apnea. But conversely, obstructive sleep apnea can cause an increase in renin, in the renin-angiotensin-aldosterone system, which then aggravates the increase in aldosterone. So there is a somewhat of a relationship between patients with obstructive sleep apnea and primary aldosteronism. And the suggestion is that if a patient has obstructive sleep apnea, it's useful to work them up for primary hyperaldosteronism and treat them accordingly, as this might help relieve a lot of the symptoms that the patients have that comes from obstructive sleep apnea. So again, important to screen for primary hyperaldosteronism, and again, aldosterone, renin, and the aldosterone-renin ratio. But largely, as we all know, lifestyle changes for these patients. Surgery is an option that one can consider to sort of decrease the BMI, positive airway pressure, so the masks that they use to sleep with, and then also those mineralocorticoid receptor antagonists, so spironolactone. Okay, so case 2, probably quite a very common clinical picture that we encounter in the clinics from day to day. So this woman was referred to the Endocrine clinic, known with diabetes mellitus, hypertension, also had very typical clinical picture, moon-shaped face, hirsutism, osteoporosis, and some lumbar fractures. 5 years earlier, and so you can see that she's quite a young patient. So 5 years earlier, she was 23 years old. She presented to the GP purely with hypertension and was put on antihypertensives. And so appropriately given treatment to try and control the hypertension. And so we can tell from this history, it's Cushingoid appearance. So Cushing syndrome is something to consider. And you can see with the striae, because of the protein loss from the increase in cortisol, the fat deposition that we get from the buffalo hump, increases in bruising. So very typical clinical presentation of high cortisol levels or exposure to high cortisol. So Cushing syndrome, essentially excessive cortisol, a very small percentage of the actual endocrine causes that we find in hypertensive patients. But within our cohort of hypertensive patients, or in the cohort of patients that have Cushing syndromes, 80% of them are actually hypertensive. So even though it's a very small proportion of hypertension, when you diagnose Cushing's syndrome, the majority of them will have hypertension. Important clinical features just to consider. We talked about that osteoporosis. They tend to have fragile bones, so sort of the lumbar spine fractures that they present with. Again, the bruising, striae, abnormal fat deposition, and that increase in glucose, because cortisol is a counter-regulatory hormone, it will push up your glucose levels. So in diabetic patients that have this clinical appearance, Cushing's or high cortisol is a consideration. So in terms of the workup for Cushing syndrome, the main cause is they have a high cortisol. So you want to confirm that they have a raised cortisol. Actually, before I go into the workup of these patients, I want to just take a look at the two graphs on the right. And it's important just to consider when thinking of cortisol that there's a diurnal variance during the day. So during the course of the day, you expect the lowest cortisol levels at 12 o'clock at night while the patient's asleep, decreased levels of stress response, so very low levels of cortisol. At around 8 o'clock, 9 o'clock, that's when you tend to see the cortisol peak. And so in these patients, you're looking for a very raised cortisol level. So you want to confirm that they have a raised cortisol and find the source of the cortisol excess. So is it coming from the adrenal or is it coming from higher up in the pituitary? So the first thing, how do we confirm that they have a raised cortisol level? Either 24-hour urine cortisol, and the rationale for doing a 24-hour urine is because you have this diurnal variation. If you take a spot urine at one point during the day, you might miss a high cortisol. But if you do it over a 24-hour period, you have a better representation of what their cortisol has done during the day. And so you're looking for cortisols more than 485. Other ways of confirming a high cortisol exposure, you want to do a midnight cortisol. The rationale is that you expect this very low cortisol. So in a patient that has high cortisol levels, you want to see what they look like when the expectation is a very low level of cortisol. And so you're doing a midnight cortisol, either a salivary cortisol level or a serum cortisol level. There is some literature to suggest that doing a serum cortisol can potentially spike up their cortisol a little bit because you're sticking a needle into them, they're going to feel pain, it's going to be a stress response, and so that might push up their cortisol a little bit. But you essentially want to look at high cortisols at midnight. Again, looking at the loss of the diurnal rhythm is something that one can consider. But one of the more definitive tests is to do a dynamic function test, and this is the dexamethasone suppression test. So like I mentioned previously, in a patient that has high amounts of cortisol, you want to try and suppress that cortisol. So the idea is that you're giving them dexamethasone to suppress the amount of cortisol that they are exposed to, and you're looking for a level less than 50. So you want them to be suppressed when you look at that 8 a.m. cortisol, especially if they're exposed to raised cortisol levels. Okay, so the idea is that you want to look for exposure to high amounts of cortisol to give you the diagnosis of a Cushing's syndrome or Cushing's disease. Okay, so further on from Cushing's syndrome, we now need to localize where the cortisol is coming from. And your predominant cause of a Cushing's syndrome or Cushing's disease, I prefer to use the terms adrenal Cushing's or pituitary Cushing's because it localizes where the problem is coming from, and it's easier to think about it in that kind of way. So with Cushing's disease or pituitary Cushing's, that's a predominant cause of a high cortisol level. And when you think of adrenal Cushing's, it's not as much of the population that have of the hypercortisolism patients. So most of the time, it'll be a pituitary cause, and then a small percentage, they'll actually have an adrenal adenoma or adrenal malignancy that causes the increase in cortisol. And so when we look at localizing where the patient is or where the cortisol is coming from, doing ACTH and doing cortisol together at the same time at 8 a.m. is a useful indicator. And you can see from this table, depending on the direction that the ACTH and the cortisol goes, it tells you where, it kind of gives you an indication where the increase in cortisol is coming from. So if we think of coming from the top, so the pituitary level, if they have a raised ACTH and a raised cortisol, so that downward response, so from the pituitary all the way to the adrenals, the pituitary is stimulating the cortisol to produce, the pituitary is stimulating the adrenal to produce cortisol. And so that's a pituitary adenoma. Alternatively, if you're thinking of an adrenal lesion, something coming from the adrenals, you have an increase of cortisol coming from the adrenals, and negative feedback responses blocking the release of ACTH. And so you get this low ACTH with an elevated cortisol. And so that localizes where it's coming from. And then the third category is an ectopic ACTH, so coming from a different source. And you'll usually see a highly elevated ACTH because there's no negative feedback on this receptor despite the elevated cortisol. You'll still have this much higher elevated ACTH. Again, keeping in mind that your pituitary does have some negative feedback because of this cortisol when you look at pituitary adenomas. Okay, and again, when you treat these patients surgically, they tend to improve quite well. So it's important just to identify them, find the high cortisol, localize the lesion, and treat them appropriately surgically if warranted. And so when we look back at the case, we can see that a few of those investigations that we talked about were performed. You can see this daily urinary cortisol, so was greater than that 400. And so it's a very high elevation of the cortisol levels. So from the time in September, continue elevating in October. So very high exposure to cortisol. And that's confirmed on an 8 a.m. cortisol and a midnight cortisol. You can see these levels. So we talked about a midnight cortisol greater than 100. So you can see that's quite high. And an 8 a.m. cortisol, you expect the elevation of the 8 a.m. cortisol at that time. So you can see patient is significantly exposed to cortisol levels. And now when we look at the ACTH, the reference limit is 0 to 46. And we can see this patient actually doesn't have that high of an ACTH. And so with the diagnosis, they found it was pituitary. Okay, so had this extremely high cortisol levels and had this normal ACTH. So I just put this slide in before we look at the mechanism of why cortisol is an actual, why it causes hypertension. I find this slide very useful just to think about the whole aldosterone cortisone relationship. So this is the steroid pathway, and the steroids are the mineralocorticoids, the glucocorticoids, and the androgens. When you have a high aldosterone, that affects the mineralocorticoid receptor, and then you get hypertension, and we looked at that. But similarly, when you have patients with extremely high cortisol, that cortisol has an impact on the aldosterone receptor. So on that mineralocorticoid receptor, cortisol can impact on that aldosterone receptor. And that's where the hypertension comes in. It's because there's a promiscuity in that receptor, and it's able to accept aldosterone and cortisol. Further on from that, you can see that how if there's a large amount of cortisol, you might have increases in this level. Okay, so again, looking at the mechanism of Cushing's syndrome. So again, this is the distal convoluted tubule, the renal tubular cells. This is the mineralocorticoid receptor, and this is that ENaC channel that we previously touched on. So with this excess amount of cortisol, it attaches onto the mineralocorticoid receptor, and that causes the same kind of effect that aldosterone has. It causes the reabsorption, or at least the reabsorption of sodium through these ENaC channels, and pushes out potassium and hydrogen, and you get the same similar type of clinical picture that you see in hyperaldosteronism. Okay, so now moving on to renovascular hypertension. 8% of the hypertensives, it can be broadly divided into two groups, so fibromuscular dysplasia and atherosclerotic renovascular hypertension. So your fibromuscular dysplasia, commonly in children, younger, middle-aged women. And then if you want to look at the atherosclerosis, predominantly older adults. Some literature says predominantly males. Some says there's an equal presentation in men and women. And again, these patients also can present with hypertension with hyperkalemia, and we'll look at the mechanism of why that happens. And then also an increase in renin and aldosterone. So renin and aldosterone is increased, but they increase in a similar level, not to the same degree that you get hyperaldosteronism. The reason for that is that if you look at this picture, there's an occlusion at the renal artery here, at this vessel, and that prevents perfusion to the renal artery, and you can see sort of this darkening discoloration of the kidney on the right. And because there's a decreased perfusion, you have an increase in renin and similarly an increase in angiotensin 2, increases in aldosterone, and that subsequently increases the blood pressure. But you don't have that negative feedback response because you're not getting, you're not perfusing that distal convoluted tubule appropriately. And so you'll constantly have this release of renin, release of aldosterone, and this persistently high blood pressure. So there's a subtle difference to primary hyperaldosteronism, but still that high aldosterone level. And when we look at the two different kinds of renovascular occlusion, atherosclerosis, fibromuscular dysplasia, there are similarities between the two. One important thing to make note of is that in patients with a bilateral occlusion, so where there's a blockage on both sides, left and right of the renal arteries, they tend to worsen in their renal function after you give them angiotensin converting enzyme. So if you're giving them ACE inhibitors, enalaprols, the captoprols, all those kind of medications, their renal function can worsen. And it seems to be that because of the blockage on both sides of the blood vessels, they're not able to clear out the urea and the nitrogen containing elements from their circulation, and that causes an azotemia in these patients. And so that's why they can actually get much worse. And so you don't want them to be on ACE inhibitors. And so then we kind of just touched on the differences of the patients with fibromuscular dysplasia and atherosclerosis. Okay, so then the last one that we're really going to look at in depth is the pheochromocytomas. And these are quite rare, though. These are fairly rare disorders, so neuroendocrine tumors. So pheochromocytomas are from chromaffin cells in the adrenal glands specifically. So contrast them to paragangliomas, where they're not in the adrenal glands. But pheochromocytomas tend to give you a very typical clinical appearance with this very high blood pressure. They tend to have significant headaches. They sweat a lot because of the increase in the adrenaline and noradrenaline and those norepinephrines, and they get symptoms very similar to your fight or flight response. So this flushing, they'll have palpitations, they might have tachycardias, and they can present with heart failure, abdominal pain, and other symptoms. So when you're thinking of pheochromocytoma, think of increasing adrenaline, increasing noradrenaline, and those are the kind of symptoms that you might expect. And so that's all increasing your blood pressure. Other syndromes to consider are multiple endocrine neoplasias, so the MEN type syndromes. So you get pheochromocytomas as part of those syndromes. In anything that increases that catecholamine production. An important test to consider when thinking of a pheochromocytoma, so a neuroendocrine tumor in the adrenal gland, is these plasma metanephrines. So plasma metanephrines or a fractionated 24-hour urine metanephrine. And so basically it's a 24-hour urine sample collection, and we're looking for these metanephrines, and we're looking for an increase in these metanephrines. And so we're looking for 4 times, so the upper limit of the reference range, if there's a 4 times of the upper limit, then we're thinking that there might be a pheochromocytoma. But it's important to do the test more than once, so at least 2 or 3 times, do a 24-hour urine test, and that'll give us a better indication if this neuroendocrine tumor is present. Important just to think about false positives, so any medication that can stimulate that noradrenaline pathway. And so you might think of drugs, caffeine, if there's a stimulation of the sympathetic nervous system, and various other drugs that can cause an increase in that pathway. Those can give you a false positive, that can give you a false positive 24-hour fractionated metanephrine. One other simple blood test that's a bit easier is a chromogranin A, but chromogranin A is not specific for pheochromocytoma because you do see it in a few neuroendocrine tumors. So if you're looking for a pheo, the 24-hour urine metanephrine is the one to test for. Again, this is just things to avoid. It's the drugs to avoid for the metanephrines. And just to touch on the other rare causes that we're thinking about, thyroid disease, we're thinking about hyperparathyroidism and increases in growth hormone. So with thyroid disease, it's really just your thyroid function test, so your TSH, T4, possibly even T3, because both hyperthyroidism and hypothyroidism can lead to hypertension for different mechanisms. Hyperparathyroidism, you want to look at increases in calcium. You might also investigate vitamin D when looking at hyperparathyroidism. And then when you see patients clinically that have acromegaly, growth hormone is an important consideration to look at. And you might do IGF-1 as the biochemical test. And they're usually associated with some sodium retention and volume expansion, so you might see an increase in sodium. So in summary, important just to consider secondary causes of hypertension, especially the 5 that we really touched on. Primary aldosteronism, because it can present in all the other causes. But Cushing's syndrome, because of its impact on the mineralocorticoid receptor and the adrenaline biochemical pathway for pheochromocytomas. And again, we really don't want to miss these patients because of the long-term treatment that they can get and the improvement in their quality of life, giving them medication that we can target to the specific pathology and prevent that end organ damage. Yeah, I'm not really going to sort of touch on these, but again, in terms of primary hypertension or hypertension as a whole, these are good investigations just to consider when you're doing a baseline investigation for hypertension. And also looking at the screening tests for identifiable causes of hypertension. So we touched on a lot of these. The Cushing's syndrome, the pheochromocytomas, hyperaldosteronism, even thyroid and parathyroid diseases. So there's some things that you can do to give you an indication of where the cause is coming from from a screening perspective.